Good morning. Good morning. I want to thank you for coming and spending your Saturday with us. My name is Michelle Sheely, and I have the good fortune of working here at Stanford University, and specifically with the faculty here at the Stanford Medicine. So this morning you've come to hear about brain health, and it's my pleasure to introduce to you Dr. Frank Longo. He is our George E. and Lucy Becker Professor in Medicine. He is also the Chair of Neurology and Neurological Sciences and the Director of our Alzheimer's Translational Research Center. His own research is focused on effective therapeutics for Alzheimer's disease, as well as Huntington's disease and dementia. And here at Stanford, he is known to us as our rock star of science. And I want to explain to you why he has that reference. And that is because in the year 2010, GQ magazine did a national search for all the rock stars in science. And our own Dr. Frank Longo was recognized as one of those nationally. So it's my great pleasure to introduce to you Dr. Frank Longo, our own rock star.
Well, thank you, Michelle, for that kind introduction. For the next 30 minutes, we'll take a tour of how to maintain our cognitive vitality as we get older and ultimately how to prevent each one of us from getting a dementia. How many people here, I'm curious to know somebody that has a dementia? Alzheimer's is the most common dementia, either in your family or close friend or work colleague. Can you raise your hand really high? So about 90%. This is a common problem, and to be sure, as my colleagues in the other fields of medicine do a better job getting us into our 70s and 80s being fit and in pretty good shape, what we're seeing is by the time people are in their mid-80s, although everything else might be going okay, we've got about a 40% chance of having a dementia. So either each of us or the person sitting next to us will have a dementia unless we accelerate what we're doing to prevent dementia, and that's what we'll be talking about this morning, how to prevent that. So you'll hear terms, and I'll educate you on those terms. Dementia is a broad term, meaning enough loss of cognitive function to have a loss of day-to-day function, and Alzheimer's is just one of the types of dementia. There are many types of dementia, but Alzheimer's accounts for about 2/3 of the dementias. So let's take a deep dive into the brain, and to have any kind of reasonable discussion about maintaining our cognitive vitality, we do have to know a little bit about the circuitry in the brain. So what you're looking at, there are two neurons, those two blue circles, and the flow of information is going from the first neuron on the left to the next neuron toward the right. And the neuron on the left has an array of what we call dendrites. It's like branches of a tree, and those little beads along the dendrites are called spines. And then the cell body is the round circle, and it's projecting an axon that forms a synaptic connection, or a synapse, onto the spines and dendrites of the next neuron. And so the message goes along that axon, moving from left to right. It crosses that synaptic connection, goes into the dendrites of the next neuron there, into the cell body, and then again moving further to right along the axon, and then it would go on to the third neuron that's not in the picture there. So this is the basic anatomy of the circuitry in our brain. I put a circle around the synaptic connection there because that's the most delicate part. And the most delicate part of that synapse is the spine. And in the lower two panels, on the lower left panel there, we have that green dendrite. And those little nubs coming off that green dendrite are the spines. And the spines are the heart and soul of that synaptic connection. The one on the left is a normal array of spines. The panel on the right shows what happens to our spines as we age, or particularly if we end up with Alzheimer's, we have a decreased number of those spines, and the spines shrink and get smaller. And as we lose those spines, of course, the synapse no longer works well. We lose the synaptic connection, and then we lose our ability to form new memories, to speak, to know what we're doing, etc. So you'll hear about synapses and spines quite a bit. Now you know exactly what they look like. So what happens in the brain with development of Alzheimer's? We hear about two things: accumulation of amyloid plaques and accumulation of tau tangles. The amyloid plaques are those brown clumps that accumulate in the brain in Alzheimer's disease. We don't know why the amyloid accumulates, but it does. The amyloid is a fragment of a normal protein, and no one knows the exact job of that fragment, but it accumulates in the brain. It's in a soluble form that we can't see, and it's also in a form of these brown plaques. And that amyloid is very toxic to those synaptic connections. One of the best ways to wipe out that spine is to expose it to amyloid. The second process that occurs in Alzheimer's disease is the accumulation of tau tangles. Tau is a normal protein inside of neurons, and for some reason in Alzheimer's disease it forms clumps within the neurons, and then that neuron eventually degenerates. And the first thing that goes is it's synaptic connection. And so those dark blue neurons there are filled with these tau tangles. If you were here for the earlier talk about concussions, and we know that especially professional athletes that get severe brain injuries, they have this disorder called chronic traumatic encephalopathy, CTE. And in that disorder, the brain is filled with these tau tangles. So there's some overlaps with that condition in Alzheimer's disease. These are the two hallmarks of Alzheimer's disease in the brain and what we're dealing with. So let's see what happens as we go through life. First, we get age-related cognitive impairment. Now, I can spot a few people in here that are over age 29, and those few of you who are greater than 29 have age-related cognitive impairment. We all have it, and this is the gradual loss of forming short-term memories, speed of cognition, and the ability to multitask that gradually gets more challenging as we get older. Some things get better as we get older. Our verbal ability, better into our 80s and 90s. Our ability to make judgments based on prior experiences, better into our 80s and 90s, so that's good. But we do have these other critical functions that gradually decline. As they get a little bit worse, many people will form what we call subjective cognitive impairment. This is the feeling that one has when one says, my memory is definitely not quite the same that it used to be. They'll come to our Stanford memory clinic or another memory clinic. We put them through a battery of precise cognitive testing, and the score comes back as normal. Their day-to-day function is normal, and they fall into the category of subjective cognitive impairment. It's subjective because we can't demonstrate it, but they think it's different. There's no specific treatment for that right now. But then some of those individuals will go on to develop mild cognitive impairment, so-called MCI, that we're hearing more and more about. And in this situation, the person's having some memory or other cognitive difficulties. They come to our clinic, we do the testing, and we do find that for their age group, we always compare you to your age-matched controls and gender-matched controls. For your age group, you're 1.5 or 2 standard deviations below your peers. So then you do have cognitive impairment, but your day-to-day function is still pretty good. So we'll give you a diagnosis of so-called MCI, or mild cognitive impairment. Now, if one has that diagnosis, over the next 5 years, one has about a 40% chance of developing a full-blown dementia, which generally often comes out to be Alzheimer's, not always. And so in those cases, the cognitive testing, again, is impaired, but this time, day-to-day function is affected. That meets the criteria for a dementia, and in many cases, it ends up being Alzheimer's. So this is the continuum that we hope to stop dead in its tracks so that none of us ever have to deal with this. So can we detect amyloid in a living person? Certainly we can see it on autopsy. And recently, a form of PET scan has been developed where a chemical is made that is injected in the vein, gets into the brain, binds to those clumps of amyloid. It has a radioactive part of it, so the PET scanner can detect it. So that scan on your left there is the cool colors are a normal 67-year-old appearance, but the brain on the right is a 79-year-old with Alzheimer's, so we can see those bright yellow and orange colors signifying an accumulation of amyloid in that person's brain. What has shocked the field with the development of this amyloid PET scan is that we're finding that the amyloid is starting to accumulate 20 years before the first signs of memory loss. So we used to say that Alzheimer's started when the memory loss started. Completely revised that now. It's starting 20 years before. So you could be in your 50s and be perfectly fine, and you could get the scan and find out that your brain's full of amyloid. So the FDA approved this scanning about a year ago, but Medicare won't pay for it, insurance won't pay for it yet, but it's available for retail for about $5,000. And we'll talk more about whether or not you'd want to get that scan or not. So what are the risk factors that all of us are dealing with, because we're all at risk for dementia? Number one is genetics. We'll talk a little bit more about that. The second one is synapse number. Some of us are just born with more synapses. We call that brain reserve. And if one is born with more synapses, you could probably afford to lose 10% or so, and you'll still be fine. So if you do get a dementia, it'll start much later. The third factor is is education level. This raises the concept of so-called cognitive reserve. We find that people that have a very minimal education years more often will get dementia, but the breakpoints of fairly low education is generally less than high school, leads to a higher risk of dementia. But more recently, I'm seeing studies where it may not be the short number of years of education. It may be cofactors that are also associated with situations where people are not going beyond 8th grade, and it's those other factors that might be important. So we still don't really understand this. A fourth area, which is fascinating, is brain injury. During our childhood, we have a brain concussion, car accident, etc. The theory here is it sets off a very low-grade inflammation within the brain that's not causing any symptoms during most of our life, but it's thought that those inflammatory processes contribute to developing Alzheimer's, so that if we're destined to get Alzheimer's, we might get it 10 or 15 years earlier if we have this low-grade inflammation going on. Medical conditions like hypertension, diabetes, so obesity are well-known risk factors for dementia. More recently evolving ones, major stressors, as opposed to the kind of normal day-to-day stress, might increase risk. Lack of sleep is emerging as an interesting area. I'll show you some images of that. And finally, in postmenopausal women, questions of whether hormone replacement prevents dementia. That was the teaching for many years. The Women's Health Initiative studies that came out starting about 10 years ago sort of turned that upside down and said too much estrogen replacement might actually increase the risks of dementia. Very confusing area, and we could go into more detail on that later if people want to ask about that. Let's look at the genetics a little bit more. I get asked about this all the time. Today we're talking about what we call sporadic late onset Alzheimer's disease. That's about 98% of the Alzheimer's that we deal with. There is a rare form of Alzheimer's that we call familial. The onset there is very young, in the 40s and 50s. In those families, there's a very powerful gene that runs in the family. For each parent that has Alzheimer's, each of their children has a 50% risk. So we're not talking about that today. But just for the sporadic Alzheimer's, there is one gene that plays a very big role. It's called the ApoE gene. And the ApoE gene comes in three types, E2, E3, and E4. Now you might be wondering what happened to the one. They just wanted to make it complicated, but it's 2, 3, and 4. And it's the type 4 that sets an individual at much higher risk for Alzheimer's disease. So for example, if one has no family history, your lifetime risk is about 15%. You live a full lifespan. If you don't have the E4 version of the ApoE gene, you're down to 9%. That's good. If you have an E4 version of the ApoE gene, you're up to 30%. You've just doubled your risk. Now let's look at what happens if in addition, one has a parent with Alzheimer's disease, because anybody with a parent with Alzheimer's is at increased risk. So we have 2 copies of each of our genes. So if your ApoE allele is a 3-3, i.e. there's no 4, you're at about a 30% risk, increased risk, just from having the parent with Alzheimer's. If you have both a parent and 1 copy of E4, you're up to 45% lifetime risk. And if you're unlucky enough to have a parent and 2 copies of the E4, you're at a 60% risk for developing Alzheimer's. This is the most predominant gene in terms of risk. There are probably dozens of other genes that play some role in risk. Now this one is interesting because it was available on 23andMe. the DNA, commercially available DNA testing. Many of you have probably tried that. They look at a few hundred genes and you can find out your ApoE status there. Now the FDA shut them down a couple months ago, as you may have saw on the news. But I know many people that have had this testing, and when you clicked on this, you had to do a few clicks where it kept saying, are you sure that you want to know your ApoE status? We can test it in our memory clinic, but we generally don't. This DNA testing raises a can of worms. Would you want to know that you're at increased risk for Alzheimer's by your DNA testing? First question I get is, well, can I do anything about it? Do you have a drug that will prevent it? If you did, yeah, I'll get it tested. The answer is we don't yet have a drug. We hope we will sometime in the not too distant future. So that would be one reason not to get tested. Many things to think about here. You probably don't want to have on your medical record that you have a high-risk gene for Alzheimer's. If you're ever interested in buying long-term disability insurance, this is not great information to have on your record. That was the beauty of 23andMe, that nobody would ever see it, potentially, until someone hacks into the 23andMe website. And so there are a lot of careful things to think about, and probably the most critical, I have these discussions with my patients all the time on DNA testing, we can't put the genie back in the bottle. Once you find out that you have a gene that puts you at high risk for Alzheimer's disease, you can't change your mind and say, I wish I'd never got that done. You're stuck with that on your mind. And I've seen that really wipe people out mentally. So I really caution people. So most of our patients don't get this testing, but it is available. We can talk more about which person might want to get this testing done. So if a person comes to our clinic, what do? If they're worried about cognitive function, we take a careful history covering all of the medical aspects. The history is devoted to finding out if there's loss of day-to-day function. We do a careful neurological exam. We do a careful cognitive exam, quantitating different parts of cognition. We do a brain MRI scan to look for other causes of dementia. We do a few blood tests. A low B12 can present as a dementia. Low thyroid can present as a dementia. We call this whole package a dementia workup. We're about 85% accurate. That's not good enough. That's the best the technology can do now. We'd like to develop technologies to put us at greater than 99% diagnostic accuracy, and I'll share with some of the technologies that we're working on for that goal. It's still a very much paper and pencil world for us. If you come to our clinic, we might ask you to take a blank piece of paper, draw a clock, put the numbers in, put the hands in, and make it say 2:45. The panel 10 there, this was the person's first time. They only had a little bit of memory complaints. They were doing pretty well, but then they were followed over time, and look what happened to their ability to draw that clock. In Alzheimer's, one loses a spatial abilities also, and it completely degenerated. And so we use old-fashioned methods as well to monitor this disease. Here's a current MRI scan. If somebody had an MRI scan today, this is what it would look like, and people think, well, does the MRI scan show whether I have Alzheimer's or not? Current imaging technology tells us absolutely nothing about whether or not this person has Alzheimer's disease. Tells us they don't have a brain tumor that could present with cognitive impairment. Tells us they haven't had a series of strokes they didn't know about. That can affect cognition. Tells us they don't have hydrocephalus, a condition where the brain accumulates too much fluid. That can cause a dementia. So it rules out things that we can fix potentially, but it doesn't tell us directly how this brain is functioning. So we need technology that can look into the human brain and tell us something about how these circuits are functioning. The amyloid PET scans tell us if there's amyloid there, but they don't tell us about anything, how the brain's functioning. And in fact, if we took a room full of 70-year-olds with normal cognition, 1/3 of them would have amyloid accumulated in the brain. So what do we do with that information? That person's not demented, but they have amyloid. It's not telling us about their brain function. So we need to develop these, and we're doing that here. One of my colleagues in our department here at Stanford, Mike Gracious, has really pioneered in the world this technique called resting state functional MRI. It's a very sophisticated way of doing MRI imaging. And the circuits showing in orange there, especially on the brain on the left, that orange circuit are the connections to the hippocampus, the part of the brain that's particularly crucial for memory. And there's a healthy elderly person there. On the left, the person on the right has early Alzheimer's disease, and look what happened. Those orange circuits connecting the hippocampus are almost entirely degenerated. So this is the first time we can look into a living human brain and look at the status of critical circuits in the brain. This is a neurologist's dream come true. Now, technique is still under development. It's not accurate enough yet to use in our clinics, but our hope is to get it to that point where we can actually tell you how your circuitry is doing and monitor it over time and monitor the effects of treatments. So with the technology in the pipeline that we have and others, this is how I hope it'll look in 5 or so years, that when somebody comes to us saying my memory's not quite right or other cognitive functions, it's not always memory that starts first, we'll take a look at your genes, because that'll tell us a lot about your predispositions. We'll do a blood test and we'll look at patterns of proteins, patterns of fatty acids. They will contribute to our ability to predict if and when you'll develop your Alzheimer's. And we'll do one of these more sophisticated brain scans. And if we put all 3 of those things together, we'll be able to personalize for you what your lifespan outlook looks like. So you might come, and everyone might come and do this when they turn 50. So right now you turn 50, you have to get a colonoscopy. Well, now you'll come and get your brain checked. And we'll be able to have a discussion with you saying, look, when we put all this data together, it's about a 98% predictive that when you're age 85, you'll be fine. And so as we have drugs available to prevent Alzheimer's, it wouldn't be worth being on a drug that has side effects and costs a lot. If you have a 98% chance at age 85, you're fine. Other patients will put all this together and we'll say, hey, by age 65, you've got about an 80% chance you'll be in a second stage of Alzheimer's disease. For that person, I think it'd be worth being on a drug to delay onset or prevent onset. So it'll be highly tailored to each person. That's where we're heading. So that's a little bit into the future. What can we do right now, today? So what we can do now has 3 broad categories. On the left there are the cognitive exercise. Use it or lose it in your brain. And so we have POSIT sciences. Some of you may have heard of that. Lumosity. We go on the website. We can do brain exercise, visual, spatial exercises, memory exercises. And the claims here are that if we exercise our brain like this, it might improve our cognitive function in a broad way. It might even delay onset of dementia. There are many companies doing this. You pay for it. It's turning out to be a significant industry, and it's quite scientific. The middle panel there represents the so-called Mediterranean diet. Maybe the key is just to eat healthy and not be overweight. And that's supposed to decrease the chances of getting a dementia. That's emerging. And then finally, we have physical exercise that, you always hear exercise is good for you. Now, which one of these are the best? Which one has the best data, if any? If one wanted to prioritize one of these 3 strategies, what would one pick? Or do we really know anything about any of them? So I hope that by the time we're done discussing here, you'll all be experts on this, because there are endless claims. You can look at 10,000 websites today on each one of these, and I'll distill that down for you. Let's start with the cognitive exercise. And I'm mentioning the software here, but that also includes old-fashioned cognitive exercise, maybe reading challenging books and being able to discuss them, the so-called crossword puzzles, etc. Exercising our brains. And the big controversy in that field is that we've known for a long time that if one sits at a computer and does a certain task, you will get better at that task. That's not too surprising. But the big question has been, does that so-called brain exercise spill over into other areas of cognition? Does it help in a real practical way in life? If I do this brain exercise, will I be less likely to forget where I parked my car at the mall? That's been the big controversial question. I don't need to get better at this particular computer game for my life. So really the first study that's indicated that there could be some spillover effect was published just last year by Adam Ghazali's group up at UCSF. So this is the experiment they did. They took a bunch of people, older adults with normal cognitive function, they don't have Alzheimer's, and they divided them up into 3 groups. Group 1 did this driving task shown on the left. It's basically like a computer game. You're driving this car and you're sitting at the computer and you're keeping the car on the road. It requires some attention and concentration. Group number 2 had symbols flashed at them, like this green dot in this white oval, and each symbol was symbolized a command that they had to do with a cursor. So they just had to pay attention to what they were seeing. But group 3 had the hardest job. They had to multitask. They had to keep the car on the road while they were following these commands. So it's a little bit harder. It's multitasking, right? And so they did this for 1 hour, 3 times a week for a month. That was their assignment. This is done in a research environment with a research-designed software here. And then they came back 5 months later, total time 6 months into the experiment. And what they found was that tasks that weren't directly related to these tasks of keeping the car on the road, for example, working memory and vigilance, actually got better in the multitasking group. Not in the first 2 groups, but the multitaskers actually improved their ability in 2 other areas of cognition that weren't directly involved with these computer games. First evidence that there could be some spillover effect. So it was in the media because of that. It was published in a very prominent journal. The caveat here is that the effects, though, although statistically significant, were pretty small. And it's hard to know what role this might have on real life function. And there's no data on whether this would prevent or delay getting a dementia. So many unknowns. So currently there are efforts to see if this software could be made more user-friendly in a commercial mode. And what happens is just the average person like us, we're using it at home. This is done with researcher assistants in a very highly specialized research setting. So this is the best data we have of whether cognitive exercises do anything. We don't know if they prevent anything. We don't know if their effect is significant to real life, and the effect was very small, and it's just one study. And in medicine, we always like to see more than one study for an effect. And you're looking at the best study here. So let's move on to diet, and I kind of combine supplements with that. So we have the so-called Mediterranean diet, lots of fish, complex grains, not too much meat, fruits and vegetables. And so the epidemiologists see that people that have been on a Mediterranean diet most of their lives have roughly a 15 or 25% reduced risk for getting a dementia. And that's what we call a cross-sectional study. What we don't know is about the cause and effect. Does that mean that if we took this half of the room and said, go on a Mediterranean diet for the next 5 years, and then come back and we'll do cognitive testing, this half go to Burger King for the next 5 years, come back and we'll do cognitive testing, will there be any difference? That's called a prospective randomized trial. That's how you really find out about cause and effect. This is more like taking a snapshot that people on Mediterranean diet happen to be getting less dementia, but maybe people on Mediterranean diet do other things, and those are the other things that are important, and we don't know what the other things are. So we don't really quite know the causal relationship. Maybe this is helpful, we just don't know. What about coconut water, coconut oil? I can't get through 1 week of clinic at Stanford without somebody asking me about coconut oil, coconut water. And by the way, this topic of supplements is the #1 question for all our patients. They've been on the internet. They've got long lists of questions about supplements, nutraceuticals, et cetera. I can distill down about 10,000 websites pretty easily, no reliable data whatsoever. There's a group, friends of mine in South Florida, that are just starting a small prospective trial with coconut oil. Probably be another couple years before they're done. We'll see if there's any signal with that. Vitamin E, it's been all over the map. About 20 years ago, there was an article in the New England Journal showing that people on high supplements of doses of vitamin E that had early dementia had slightly reduced risk of ending up in a nursing home over about a 3-year period. But then other studies weren't able to replicate that. It fell out of favor. And then finally, about 10 years ago, a study came out showing that people on high doses of vitamin E had about an 8% higher chance of dying. And so a few of my patients said, why are you killing me on the vitamin E? So it's been all over the map. And then just to make it more confusing, a few months ago, a study showed that in patients with mild to moderate Alzheimer's, those on 2,000 units a day had a 19% reduction in the rate of decline of activities of daily living. So their activities of daily living are monitored. However, there was no beneficial effect in cognition itself. So again, it's a murky area. Omega-3 fatty acids, the things that we get from fish and other sources, A study was done in mild to moderate Alzheimer's disease. They took 2,000 milligrams per day. Many of you are probably taking fish oil. You always need to know how many milligrams you're taking in those capsules. And they found no overall effect. This is the only control trial in Alzheimer's. But one big caveat, though, in that study, in the patients that didn't have the ApoE4 high-risk gene, the ones that did not have that, they did have a small effect from the fish oil. So maybe there's something there, but we don't know, and it's just one study. High doses of fish oil or omega-3 fatty acid could potentially increase bleeding tendency. So if somebody were on Coumadin or one of the blood thinners for atrial fibrillation, there could be some issues there. I wouldn't just start taking this without talking to my doctor first. We have no evidence of whether it delays onset of dementia or slows progression. And then finally, turmeric, the spice that's used in Indian food. About 5% of turmeric is this compound called curcumin. There's been the interest in the curcumin as a powerful antioxidant. Maybe it could slow down the Alzheimer's degeneration. People like to cite the fact that in India there's less Alzheimer's disease. I was curious about that. I looked into where this urban legend comes from. Turns out there are two little tiny studies from two little tiny towns in India with just a very small number of people, and they had a little less Alzheimer's there. And that's it. Here's a country with 1 billion people, and who knows, in those little towns, maybe they walk more, or maybe they do other things more. So I don't think you can say that curry is the reason why India has less Alzheimer's disease, and there's the demographics, the aging, et cetera. A small trial was done at UCLA by a group there that's been very interested in curcumin, and it showed no effect whatsoever. So my take home on these supplements is that unfortunately there's probably no easy ride. Even though it's a $20 billion a year industry, I'm not seeing any easy answers with taking a supplement. Maybe Mediterranean diet's a good idea. It might be good for heart disease and cancer, so that might be a good one. What about exercise? This is Audrey Larry. The Stanford the Olympic senior games were at Stanford 5 years ago, and this was when she was 75. She set 5 new world records. Now, fortunately, all of the exercise I will be talking about is nowhere near this. So get this image out of your mind. You don't have to be Audrey Larry. So that's not the excuse not to exercise. So let's look at something much more modest. This was the Excel study done up in Seattle with women in their 70s who had a diagnosis of MCI, mild cognitive impairment, and we talked about that being a precursor to Alzheimer's disease in many cases. So for 6 months, they had 2 groups randomized to, one group did twice a week of resistance training with weights, and they had a coach pushing them pretty hard. And then the other group did a much easier little balance and toning in the same gym with the same coaches. So this is a prospective randomized trial. This is a well-controlled trial to see if just 2 days a week of working with these weights would do anything, and it did. After 6 months, these women with mild cognitive impairment, they probably already have amyloid in their brains and tau, had significant improvements in executive function and associative memory function from just 2 days a week. I thought that was remarkable. Let's look at a walking study. So this study was done, and the people were assigned to a brisk walking, enough to get the heart rate up a little bit, starting at 10 minutes a day, gradually building up to 40 minutes a day. And they were followed for 1 year. And the outcome that was monitored, especially, was the shrinkage of the hippocampus. So you've heard me mention hippocampus a few times, the delicate key part of the brain. It shrinks with aging. It really shrinks with Alzheimer's disease, critical for memory formation. And in a normal person, it shrinks 1 or 2% per year. Now, that doesn't sound like much, but you add that up year after year after year, you're in trouble, right? So the question here is, and you can see the rate of shrinkage with that red line there, and the question here is, could that slope of decline be lessened? Could we get a little less shrinkage in the people that walked 40 minutes a day, 5 days a week, compared to the people that didn't? So I'll show you what happened with this study. They didn't slow the shrinkage. They reversed the atrophy. In the walkers, the hippocampi got larger, as if somebody put them in a time machine and lowered their age. This was remarkable. This really just blew everybody away. Now just think about this. If I had a drug that I claimed that it could reverse the shrinkage of your brain, you probably wouldn't believe me. But if you did believe me, I'd have to say it's a very powerful drug. And all powerful drugs have side effects. There's no free ride with drugs, right? So doing my job as a physician, I have to inform you on those side effects. Well, here are the side effects of this treatment. Less depression, less hypertension, and less diabetes. That's the side effects here. So now not everybody can walk, and so yeah, I'm careful about discussing this with my patients. I don't want somebody to go out and fall and come back with an injury, and then I've done more harm than good. But some people have to modify what kind of exercise they do. Not all my patients can do exercise. But the ones that can walk, I tell them they have this amazing, powerful gift. And I'd say about 90% of the time, they've decided not to use it. And what fascinates me in a memory clinic is that people come in with grave concern about their memory and cognition. They've spent hours on the internet. They can tell me about every nutraceutical in the world. They're generally spending some big time money on them by that point. They're concerned about their memory, and I just have one really simple little question. Tell me about your exercise. Oh, I don't have time for that. And it's just remarkable from a neurologist perspective, and you know about this, and you think about that. And is this relevant to all ages? Yes, it is. So they're testing children now, and it turns out that the most powerful predictor of academic achievement in both verbal scores and mathematics scores is not whether your kid goes to a private or public school, or what kind of teacher they have, or what kind of curriculum they have. The most powerful predictor is aerobic capacity. That's just remarkable. So when a school is having a budget problem, what's the first thing they cut is PE. So this biology is just coming out now. And it's not only academic achievement, as I've listed here. You can do brain scans on these kids. Their brain structures are larger, especially in the hippocampus, especially in areas that involve multitasking, areas that involve ability to have attention, in kids that have a high aerobic capacity. It's just remarkable how powerful physical exercise is. So I would sum this up by saying, in terms of brain exercise, no data. In terms of Mediterranean diet, maybe some reduced risk. We'll see, but we unfortunately don't have prospective data. Exercise, lots of data, big effect, and that would be the one I would prioritize if I was just looking at one of these. Sleep and Alzheimer's, I'll wrap up in a minute. This is an emerging area, and one study found that people with less than 6 hours of sleep have more amyloid accumulating in these amyloid PET scans than the people that had more than 7 hours of sleep. This is just new, so we really don't know the role, but the idea is that maybe during our sleep some of this amyloid is cleared. People have done trials using antibodies to try to clear amyloid out of the brain as a therapy. Unfortunately, all of these big trials in the last year, they came out, none of them, although they cleared some amyloid out, made the patients significantly better in terms of cognitive endpoints. So we have a ways to go there. Our own group here at Stanford is developing many therapies. One is based on this BDNF protein, brain-derived neurotrophic factor. When we exercise, our BDNF levels go up. When we age, they go down. If we have Alzheimer's, they're low. It's a protein. It can't be used as a drug. It won't get through the blood-brain barrier. It won't last in the blood long enough. So we're the first group in the world to create a small molecule drug that mimics a key part of that protein shown in red. And we have a lot of mice here at Stanford that have Alzheimer's disease. And a normal mouse is showing on the left there, a hippocampal neuron shown in white with a beautiful array of dendrites and spines. The Alzheimer mice have shrunken dendrites, but when we give those mice one of our drugs, it largely recovers that dendritic tree. So we can reverse dementia in an Alzheimer's mice. And we're trying to get these drugs to humans. And to do that, we have to go through this drug pipeline where we do early research, and then large pharma will pick it up towards the end when we prove it works a little bit. But that middle part we call the valley of death because nobody wants to fund that. And that's why a lot of therapies don't go through. So our vision for the future at Stanford, we'll be opening a big, beautiful new neuroscience clinic over on Quarry Road. It'll be state-of-the-art in the United States. And what we'll do there is promote brain health. We'll encourage people to exercise. I'm hoping everybody will be wearing some kind of device that I can see on my computer if they're exercising or not. They might get a text from me saying, what's going on today? And we're going to develop better brain imaging and create therapy. So we'll stop there and take some questions. Thank you. Yes. Yeah, what do I think about yoga? From what we know now, we don't have any evidence that shows that any exercise is better than any other. I think the idea is modest exertion, however one would like to achieve that. How do we define modest exertion? We have a few rules of thumb. One is that after about 10 minutes, you're starting to break a sweat. A second rule of thumb is if you're, say, walking briskly with a friend, you wouldn't be comfortable having a normal conversation. You'd be a little bit too out of breath to do that. Just modest. You could have short sentences. The third and probably most accurate, but the most difficult, is shoot for about 65% of your maximum heart rate. So to calculate your maximum heart rate, take 220, subtract your age. That number is your maximum heart rate. Calculate what 65% of that is, but then you have to know how to accurately measure your heart rate. So anything that creates modest exertion. I'm trying to be in order. I'm sorry if I'm missing people. Go ahead, unless there's somebody else. Right. Yeah, so does exercise help reduce the buildup of amyloid or help remove it? That's not known yet. Exercise is probably a lot more than just blood flow. It releases proteins that probably do really good things, and it probably quiets down the immune system. As we age, our immune system gets overly revved up, and that's why we get arthritis and other conditions. And exercise is one of the most potent ways of dampening over-responsive immune system. So it probably doesn't remove the amyloid. I think exercise is effective because of what it releases and dampening down the inflammation. I would make the point, though, related to your question, we saw that ApoE4 gene, what a big effect it has. So one study has come out showing that people who exercise completely negate the effect of the E4 high-risk gene. Isn't that remarkable? I mean, you could say, it's too late, I can't change my genes. That's how it can be done. Okay, who's had their hand up the longest? How about back there? I don't want to miss anybody in the back. Right. Yeah, that's a question that comes up. Is there a plateau effect, or is more exercise better? What the federal government, CDC, recommends, and the American Heart Association, American Cancer Society are consistent with this, is the 30 minutes a day, 5 days a week. So these studies tend to be oriented along those lines. I personally like 40 minutes just to be safe, because I won't get a second chance until we really know. So I think it's unlikely going way beyond that does much more, but we just don't have the answer. So if you enjoy a 1 hour workout, it might be helping you a little bit more, but we don't have the data for that. Yeah. Yes, you're asking about big data, how that'll help. And I think it'll help further refine the epidemiology and understanding the risk factors, understanding lifestyles that are protective or beneficial. The more data we have about these patient populations, the better. So there already has been one big data Alzheimer trial. It's called the ADNI, where about 1,000 patients have had their brain scanned, their blood taken, their spinal fluid taken, their activities monitored, and we have a few of our faculty that mine that data. And they're really learning a lot from doing that. And so I think by having big data, we'll be able to monitor therapies more effectively as well. Yeah.
To cut this...
Okay, and I can stay around if people have questions.
Thank you. So that would be wonderful. So Dr. Longo will be available in the foyer if you'd like to continue asking questions. Thank you, Dr. Longo,
Sure.
for this
My
wonderful,
pleasure. Thank you. Thank you.
informative.
Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.